France, Italy, Germany, Austria, and Liechtenstein. Little country, little city, little surgeon. We have very few experience of big cases as yours. The Swiss is recognized for the mountain, for the food, chocolate, fortunately, the cheese, the watches, the bank too, and is recognized thank Roger Federer. The Geneva city is a very small city, 200,000 inhabitants only, and the region is 500,000. But it is an international city. We have many institutions, many organizations. It is the headquarters of the United Nations. We have the headquarters of Red Cross, the headquarters of Mondial Health Organization, and the Refugee Organization too. There is a Brazilian community in Geneva, around 5,000 Brazilians. There are many illegal immigrants in Geneva, and we see that there is more women that migrate in Switzerland for wedding reason. The Swiss men like Brazilian women. It's natural. We had some very famous football players, Sonny Anderson, José Sinval, that may greet the club of the football of Geneva. The Swiss people and the Geneva people keep a bright memory of Sergio de Mello. It was High Commissioner for Refugees at the United Nations, and he was murdered in Iraq in 203, and it is buried at the Cemetery des Rois in Geneva. It is the cemetery where all the important people of Geneva are buried. Geneva is also, Switzerland is also recognized for orthopedics. And I show you the father of orthopedics, Jean-André Venel, that, which developed the practical application of orthopedics. The first orthopedic clinic was created in Orbe, a little city of the French part of the Switzerland. But you know, I think the Swiss orthopedics by the AO Foundation. AO Foundation do not mean Association for Osteosynthesis. The real name is a German name, Arbeitsgemeinschaft für Osteosynthesefragen. It's more difficult to say it. It was created by Martin Algover, Maurice Müller. Maurice Müller was considered as the greatest orthopedist of the last century. It was created also by Robert Schneider, Walter Bandy, and Hans Villeneuve. And the AO course started in 1960. I will just give you a look how the resident like you start the education in orthopedics. There is a basic surgical education, 1 year, and a specific orthopedic education that must last at least 6 years. During specialization, the candidate have to have many examinations, many exams, a basic surgery exam, an exam of anatomy and surgical approach in orthopedics, a bone tumor exam, an exam of pediatric orthopedics, and sure, every resident has to fulfill an operation catalog. At finally, there is a final exam, two parts, an exam, MCQ exam, and a second part with an oral examination. You can see my hospital. The hospital where I'm working, it's not mine. The general hospital for adults and the hospital for the children. As said before, small city, small hospital, only 500,000 habitants in the region, less than 100,000 children. Our pediatric orthopedic unit has a number of subdivisions. We take care for trauma, arm, legs, and spine. We take care for general pediatric orthopedics, malformation, congenital hip dislocation, club feet, tumor, acquired bone disease. We have a subunit for spine disorders, scoliosis, kyphosis, and spondylolisthesis. Unit for limb reconstruction, correction of inequality and deformity, hand surgery, neuroorthopedics, and sport medicine. Our staff is very small, 4 senior surgeons only, 2 clinic assistants, 3 residents. So it makes me impression to see so many people in the room. We have 10 beds and 2 or 3 beds available in ambulatory unit. The number of consultation, 13,000 a year. The patients are referred by pediatrician. They are also referred by in-state orthopedists and from other hospitals. The number of surgery, 2,500. Emergency, 1,000. Elective, 1,500. So we have the great chance to have an excellent insurance system for the health in Switzerland. But it has a cost, a great cost. So there is an insurance for sickness and maternity, only for illness, not for the trauma. And this insurance is mandatory. You have to pay it. The people that don't have some possibility can be helped, but everybody has to pay something. Even if you pay the insurance, 10% of ambulatory costs are paid by the insured persons. It's not because you have paid that everything is due. There is something to pay more. But all the costs due to hospitalization, I pay by the insurance. There is another insurance for accident at work, occupational disease and professional illness. It is also mandatory. The employers pay for professional and illness and accident, and the insured person pay for the non-professional accident. And there is a third insurance. It is called insurance for invalidity. It's not only for the rents for invalid person, but this specific insurance will support the expense related to congenital affection. So 3 systems for paying the fees. So this insurance will support the medical fees, all the ambulatory consultation with all doctors. Only 10% of the fees are paid by the insured. It will support the fees for hospitalization for illness, hospitalization for an accident, hospitalization for congenital disorders completely. There is also a system of Swiss private clinics, but they require private supplementary insurance. Fortunately, in Switzerland, the level of public medicine, I think, is high, and so the difference between private and public practice resides in the hotel industry. To have a nice room, to have a nice nurse, and to have flowers and champagne. Unfortunately, as the people pay a lot, the client is king. I pay, I want. But if you see, for you Brazilian, what is the tax every month for the basic insurance, it's a lot. 2,500 reals. I know last night we speak with some people that do not win this money every month, and it's incredible. But it's the cost we need for functioning. But this period of dream, I think, is fast over, because we can see that the cost and the expense of Swiss health system increase more quickly than the gross national product, and there will be a moment at which it will be necessary to make choices. Or we continue with the high-level medicine, the cost of the high-level medicine, or will decrease the level. Marco asked me to speak about progress that impact to my professional practice, and I think a lot about this question. The first improvement that really changed my life of orthopedist was the computerized patient. It's incredible to say that. It's not a new technology or more means. It's to have the data of the patient very quickly. All data are collected in the chart available. The access to the seat with the fingerprints, like the James Bond. You put the fingerprints and the system open. There is the possibility to consult the seat remotely. If I take my iPhone just now, I can open the medical chart of one of my patients. We have the provision of an excellent software for reading and performing measurement on X-ray. We have also a coding system according to the pathologist, and it's really a big help for studies. The possibility to include a confidential note in the document. So it is the software for reading the X-ray. We have a lot. You can see that all the X-ray are collected. Just to have to click on an X-ray, and when I have to do some measurement. I have a lot of possibilities for measuring the angle, the curve angle. I can do a measure of a surface. So for me, it's a big help to have this possibility. The revolution that I like a pediatrician orthopedist was the polymer PCR assay for detecting pathogen in osteoarticular infection. In the past, one of the biggest challenges in pediatric osteoarticular infection was to have the bacteriological diagnosis. And the rate of negative culture in children clinically considered to have an osteoarticular infection was very, very, very high. 30 until 50% for bone aspirate, 40 to 50% for synovial fluid specimens, and 50 to 70 for blood cultures. So at the end of the investigation, we have some bacteriological diagnosis in more than half of cases. So for many years, we had just a poor view of the bacteriological reality in osteoarticular infection in children, like the sailors that just see the image part of the iceberg. The wind of change started in 1983. This date, Carrie Mullis won the Nobel Prize for the development of polymerase chain reaction technology. And since that time, there was a real improvement of detection of bacterial pathogen. Starting winter 206. It was very, very cold, as you can see. Huh? It was near Nyon, and all the cars were full of ice. I don't think that you live such an experience. In the Hospital of Geneva, we start the use of PCRSI in 203, and we use intensively this technology since January 206. In December 206, I obtained a specific test for Kingella kingae, and the provision of this PCR assay permit us to demonstrate, firstly, that more than 50% of all pediatrics osteoarticular infection are due to Kingella kingae, in our experience. That in children aged between 6 and 4 years, more than 90% of infection are due to this pathogen. Unfortunately, this infection is not always well recognized, since they are clinically and biologically few symptomatic, and this pathogen is very difficult to cultivate. So I think that the use of PCR assay is mandatory to confirm the diagnosis. We try thereafter to understand what was the role of oropharyngeal carriage during infection. For Kingella is a frequent component of oropharyngeal flora of young children, but it must colonize the oropharynx before penetrating the bloodstream and giving some infection. And we demonstrate that all the children with an infection due to Kingella kingae had a positive PCR on throat swell. During this time, we demonstrated that asymptomatic carriage in the Geneva population was less than 10%. We tried, therefore, to define the value of indirect detection of Kingella kingae by PCR on the throat. And we demonstrate that the detection of Kingella kingae at the level of the throat in children that has symptoms of infection provide conclusive evidence that it was suspected to be responsible for the infection. On the opposite, the absence of the Kingella due to at the level of the throat provide conclusive evidence that Kingella is not responsible for the osteoarticular infection. So a positive predictive value of 90%, a negative predictive value of 100%. But I'm also a surgeon. I do not only throat swab. So in my experience, in my practice of surgeon, what improved the most my activity is the obtention of external circular fixation system, a standard realizado, but with an association with software for correcting deformity and trauma management. So it is like the realizado for the dummies. You have the same component, the ring, full ring, partial ring, wire pins, and all the system is connected by struts. And the patient will act on the struts. There is also a software for managing most of the deformities, axial deformities, rotational deformities, shortening, mixed deformity, pseudarthrosis, bone infection. We speak about rickets a few seconds before. We have this case of rickets, resistant rickets, and it's evident that it cannot be correct in one step. We have to perform a gradual correction. So the fixator is put in place, but like a usual is off, but we have the possibility with the software to put inside the machine, inside the computer, everything that we want to correct. Varus 40 degrees, apex anterior anticurvature 20 degree, rotational deformity, and we put all the data of we want to correct. The external fixator is put in place. The machine just need to know how the system is implanted on the bone, and we start with correction. You can see that I perform at the same time a correction of the distal femur. I put the system, I choose the cora for performing the osteotomy, and we start with correction. And after, I think, 20 or 30 days, we have a full correction of the deformity. We did exactly the same with the other legs, with the final result that was satisfactory. Another problem of sequela of meningococcemia. We have a big discrepancy of the length of the legs considering the total body. A varus of the tibial proximal, a valgus of the femur distal, and a big varus at the level of the ankle. In this way, we perform all the calculation before the surgery. We choose the cora. We put the system in place, and we start with the correction. In this case, we start with a little lengthening in order to facilitate the correction. On the other side, we did exactly the same. A lengthening at this point, a correction of the varus at this point, and at the end of the process, we had this X-ray. You can see that I perform also a lengthening of the femur, both sides. I choose a nail on this side and a LRS system of the other side. Finally, I have still another improvement that improved my practice. It is the limb lengthening with intramedullary motorized nail. This is not the mechanical lengthening process. It is a lengthening device with a small magnetic motor inside it. You can see it here. And so it is put inside the bone like an usual nail, but you can activate the motor with an external remote controller. It is this part of the machine. And the patient will do by himself every day, 3 times a day, the lengthening process. And there is the possibility, it is the first nail that permitted to increase the length, but if there is too much, you can go backward. Yeah. And you can use it also for pseudarthrosis. Very easy to use it. And the patient, the children can do the job by themselves. Just to put the special device at the right point, at the level of the motor, and to perform the lengthening. It lasts, I think, 1 minute for every millimeters. And you can divide it in 3 or 4 times a day. The last cases that I performed, this girl came to me because there was very discomfort by upper limb discrepancy, and I perform a lengthening of the humerus 5 centimeters, and I had many doubts about the stability of the joint. But there was absolutely no problem. She recovered perfectly, and we have stopped the lengthening last week. And another case, this young girl had a discrepancy. I think it was 4 centimeters, and he had a little valgus deformity. And we do all the correction at the same time. By putting a polar screw, we can direct the nail as we want. And after 10 days, we start with the lengthening process. Usually, I try not to cut both bones at the same level. And it's important to do a fixation of the tibia to the peroneus proximally and short distance. Less cases, you can put the femoral nail anterograde, you can put it retrograde. In this case, I chose to put it retrograde because there was also an angular deformity. You can see that I put 2 polar screws and I correct both deformity in the same time. And we start with the lengthening process. It was just show the boy how to act it. It was 2 days after the surgery, and very quickly this patient go outside and they perform the first lengthening in the ambulatory session. So it's all for what I want to say to you. You can see that my city is also beautiful. It's more. We have not Corcoval, we have not the Pan de Asugar, but we have the lake, we have the jet d'eau. I propose to you to come once in Switzerland and to visit my country. Thank you very much.
Thank you, Dimitri. Fantastic material. I will start with a first question. One of the biggest problems in the system is to introduce new technology, as last one slide you show us. So how is it in Switzerland? Who pays for that? Is for every patient, or the doctors still have the manager of this kind of thing?
It's becoming difficult here in my country too. We have to justify that it is the best treatment. But there is no limitation. There's no limitation of technology for the patient. If the right treatment is this one, we have to secure the insurance that it is the best treatment.
Okay.
But there's no, for the moment, there's no limitations.
But there is any guideline for doctors to choose a better surface for joint replacement?
Unfortunately, the guidelines are given by the insurance.
Exactly.
And it's in any situation, it may be difficult to justify the treatment, but you have to fight for your patient. And it is a big part of my activity to explain the insurance that is the right treatment for the right patient.
Alguém? Eu tenho a segunda pergunta. I have a second question. You show us a very interesting situation about the joint infection. One of the problems of our system is for the long-stayed patient in the bed for antibiotic treatment, or someone old with a hip fracture and some dementia who needs to have specific cares. You showed that you just have 10 beds in your hospital for surgery. So how you take this patient out for your hospital to have a new case to do surgery?
Pediatric.
Yes.
Pediatric.
Just pediatric.
Yeah. So we have some infection, but hematogenous infection. Very rarely we have a material infection. In these cases, we have to keep the patient in the hospital, of course. But it is only a little rate. It is not like adult surgery. In adult surgery, we have a department only for infection, for device infection, for amputation, for this kind of problem. In children, it's not a recurrent problem. It is a rare problem, fortunately.
Dr. Dimitri, your hospital, how many beds for orthopedic? I understand it's 10 beds for kids, no? But at all? Orthopedic beds, how many?
A very big hospital, we have around 150.
150. Do you know how many surgeries you do a year for orthopedic? You have, you know?
I think I'm between 75 and 35.
Okay. And
The senior surgeon, professor, assistant, clinical assistant, and rest.
okay. And I suppose Switzerland is a very civilized country. There is not so much accidents, car accidents, car crashes, or road injuries, but you have a lot of accidents in ski because you have ski resorts.
Yeah.
Is that a case that you have a lot of trauma?
Skiing is becoming a real problem. A real problem of public health because the Swiss people like skiing, and every year there is an increase of the traumatology. The material is always more performant. The pistes are very prepared, and the people are not prepared for skiing so quickly.
Yeah.
And we have very many accidents with skiing, especially at the level of the knee. And I think it is becoming a problem of public health, because somebody who broke the knee is outside of the work for many months. If he has not a functional work. If you have to go to outside for building a house, it's not possible for 6 months or 8 months to walk.
Yeah, I understand there is a real problem. Like us here, we have traffic accidents as a real problem because nobody stops at the red signal. So that's a catastrophe.
I saw that. It's,
you saw that in Rio, no?
It's like Italy.
No, it's like in Italy. Yeah, sure. Yeah.
Thank you. When I went 20 years ago in Rome, for me it was a little panic in order to drive my car.
Alguém? Talking about trauma cases, even if Switzerland is a small country, you have different trauma centers around the country, and all the care is taking these satellites hospital, or you have a big center which all the patients go after the primary care?
Yeah, there are many regional hospitals. For example, in the Valais, the region where the people are skiing, there are four regional hospitals that give the first care for the accident. And thereafter, if there is some difficulty for taking in charge the cases, they send the cases in other reference hospitals like Lausanne, Genève, like Geneva, Basel, Bern, Zurich, Winterthur, the big hospitals.
So my last question is about research. How you do the translation about your practice in the OR to the research? How you deal with this, with the labs and everything?
I think that's the first thing that is important for see patient. If you don't see some patient, you can do some research. So it's very important to have a staff. Different subject of studies. We have a team of studies about infection, a team of studies scoliosis, a team of studies, and we collect data. And we have the change the log to have the system that permit you to take outside all the patient considering the pathology.
But you have your specific research team, or is a research team for all the hospital?
No.
All the university?
You have to create it.
Yeah, okay.
Yeah. And you create your team and during the office hours.
And it's a financial resource outside of the practice, or is the same money for everything?
It's very difficult. You can try to obtain some bursts for doing your research, but most of the time we have very few financial support. You can try to have some association with the industry for paying your.
So you have a near relationship with the industry and everybody.
Still for the moment, but I think it will change in the future.
Okay. Uma coisa? João.
A question about medical recertification in Switzerland. You are a surgeon, okay?
Yeah.
You need to some recertification during your life?
Yeah. The system is changing. You have to do the final or the exam during your training, and after I think it will enter in consideration to do a recertification every 10 years. And 10 years ago, I have to spend a little time in order to revise the subject that I do not know anymore. I'm not a specialist for the shoulder surgery, for example, but I have to study again in order to do the examination.
It's like a test or some meetings that are...
No, it's mandatory to participate to congress,
okay,
to educational journey, but
papers maybe to
publish,
yeah.
soft code, blah 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 blah, AO course. you have to do some course every year.
Okay.
And every 10 years you have to do a recertification.
Okay, thank you.
And there is a system of points. If you publish a lot, you gain some points. If you go to the Congress, you gain points. And you have to have a quota of points every year. Okay.
Mais alguém? So, Professor Dimitri, thank you very much. Professor Musafi, obrigado por ter ajudado a viabilizar a vinda dele. Até a próxima. Obrigado, gente. Bom dia para todos. Obrigado. Thank you. Nice, very nice.
Muito obrigado.
Não, muito legal.